Modified belt loop technique for subluxated intraocular lens, capsular tension ring and capsule complex fixation. Late intraocular lens subluxation or dislocation is an uncommon complication occurring after cataract surgery. However, the incidence rate ranges from 0.5% to 3.0%. In the near future, incidence rate should increase because of highly improved phacoemulsification techniques, which allow implanting intraocular lens in the bag even with severe zonular weakness. In late in the bag dislocations, there are two surgical management options: IOL exchange or IOL fixation. Usually, IOL exchange requires either anterior or even posterior vitrectomy, and IOL fixation may be performed without vitrectomy. As intraocular lens fixation technique is minimally invasive, it tends to be chosen more often for IOL in the bag subluxation in recent years. Many new techniques were published for IOL fixation and exchange. One of widely used IOL fixation techniques is double belt loop technique by Dr. McCabe. In this technique, the author suggests passing one end of 6-0 polypropylene suture underneath a dislocated haptic of IOL in the bag and another end of suture above the IOL haptic. Then another loop is formed around another haptic. However, we found this technique has some limitations as it is not suitable for hydrophilic IOLs because of IOL slippage from formed suture loops. Also, when performing this technique, IOL tilt may affect post-operative refraction, and IOL centration could be challenging during surgery. When doing one of double belt loop IOL fixation surgery, after a second IOL haptic fixation, we constricted pupil and we noticed an IOL decentration. As in the bag there was CTR, we used a third loop to achieve good IOL centration. In another case, we used double belt loop fixation. However, a third loop around CTR was necessary for decentration correction. In post-operative examination of this case, we noticed an IOL tilt backwards in the quadrant where no suture loop was performed. For the next case with IOL and CTR dislocation, we planned 4 belt loop fixation. Steps of modified belt loop technique. In cases with late in the bag IOL and CTR dislocations, we recommend the 4 belt loop technique. During this technique, 4 loops are formed: 2 around the haptics of IOL and 2 around the CTR. In this way, we can easily adjust IOL centration and minimize IOL tilt. In this modified belt loop technique, we firstly recommend making a loop around the IOL haptic, which is decentered most. Thin wall 30 gauge needle is passed to sclera under IOL haptic. Then 6-0 polypropylene suture is inserted to the lumen of the needle. Then the needle with a suture is pulled out of the eye. Another sclerotomy with a 30 gauge needle is performed closer to the limbus than the previous one, and the needle is passed above the haptic. As the other end of the suture is inserted to the lumen of the needle, with suture is pulled out as well. Both ends of the suture are tightened so the loop around the haptic is formed. Then the second loop should be formed around the second haptic. We recommend performing scleral tunnels in a counterclockwise direction. This way, IOL haptic will have less chances to slip out from the formed loop. The third and fourth loops are formed around CTR in other quadrants. It is hard to visualize CTR in a capsule, so a use of an iris retractor could be beneficial. As all 4 loops are formed, then, by pulling each suture IOL complex could be easily centered. Only then, when the surgeon achieves satisfactory centration of IOL, sutures are cut and final flanges are formed. This 4 belt loop technique allows fixating even IOL and bag complexes with severe dislocations. We have performed 4-belt loop technique for dislocated IOL, CTR, and capsule complexes to anterior vitreous, or for cases with vitreous prolapse. In these cases, we recommend performing anterior or posterior vitrectomy. In this case, and in other cases presented in this video, the visual acuity after the surgery was better than we expected, and no IOL tilt was noticed. However, this technique is best for patients who were happy with their vision prior to the dislocation. Also, usually it is hard to see CTR during preoperative examination, so medical records from primary surgery are valuable. The 4-belt loop fixation technique has some advantages compared to other techniques. It becomes more easy to center IOL, as well as less likely IOL tilt. When fixating IOL with 4 loops, it is easier to reach effective lens position, and it is simpler to get good post-operative refraction. During fixation with IOL, CTR, and capsule complex, we have noticed that vitreous prolapse to the anterior chamber is less often observed than only an IOL fixation. During surgeries, we have noticed that in cases with weak zonules and without CTR, capsular bags shrink around IOL, so in one axis, capsular bags only range about 6 millimeters. Although in cases with CTR, the capsular bag in both axes shrinks only to 11 millimeters. Moreover, fixation with CTR can be applied even for hydrophilic IOLs. However, the 4-belt loop technique has some limitations. It is harder to visualize CTR during surgery, so iris hooks are beneficial when performing this technique. Time of surgery doubles if compared with double-belt loop technique. Another considered disadvantage could be higher risk of endophthalmitis. But as published 5-year results of flanges evaluation revealed, endophthalmitis risk is not higher if technique is performed correctly and if long scleral tunnels are made and proper size flanges are formed. As in all techniques, it is important to select patients correctly. This technique should only be chosen if both IOL and CTR are completely in the bag. We found that 4-belt loop technique should not be performed in cases with dead bag syndrome because a fibrotic capsule provides additional support and a capsule without any fibrosis may tear. So Emmering's ring is an additional relative contraindication because after fixation, UGH syndrome may occur. This technique cannot be applied if previously implanted CTR size was too small and there is gap between 2 CTR eyelets. We believe that this minimally invasive technique could be a surgical option to fixate dislocated IOL and capsule complex where CTR was implanted.